Hi again. Welcome back to Protect, Prevent, Preserve Your Eyes. Once again, my name is Elizabeth Nystrom, a Master of Public Health student at Michigan State University, and this is Olivia Moni, a Public Relations student at Baylor University.
We will be your guides for this educational podcast, which will look at various eye conditions, risk factors for developing these conditions, and what you can do to aid in preventing some of these conditions.
We both work for Association for the Blind and Visually Impaired, a nonprofit organization focused on helping those with vision loss thrive in a sighted world. More background information on ABVI, the services offered, and ways to donate or get involved can be found on the website, abvimichigan.org.
For today's episode, we will be discussing how smoking and UV exposure separately affect eye health, and we'll have a little Q&A session with ABVI's occupational therapist about low vision, devices, and aids. With that, let's get started.
This episode of the podcast will be a little bit more technical because there is so much data and so many studies that demonstrate the negative effect that smoking has on our health and our eyes. These studies deserve to be listed by name when applicable.
Smoking tobacco harms nearly every organ of the body, increases oxidative stress, and creates inflammatory responses in our bodies, both of which have been shown to negatively affect our overall health and eye health. The CDC reports that nearly 1 in 5 deaths are related to cigarette smoking. Tobacco use increases the risk for heart disease, stroke, and lung cancer significantly.
In terms of eye health, smoking has been shown to increase intraocular pressure, which is a risk factor for developing glaucoma. More specifically, smoking is a significant risk factor for the development and progression of cataracts, AMD, and diabetic retinopathy.
There is a huge body of evidence that links tobacco use and AMD and cataract formation. Yet the literature directly linking tobacco use to glaucoma is conflicted, and most of it surrounds intraocular pressure, as previously mentioned. If you recall from our last episode, intraocular pressure is the pressure within the eye.
One study, the U.S. Twin Study of Age-Related Macular Degeneration, or AMD, found evidence that tobacco use increases the risk of AMD. Particularly, participants in the study who currently smoked were 1.9 times more likely than never smokers to have AMD. Additionally, individuals in the study who were former smokers also showed an increased risk for developing AMD.
Back in our first episode, we discussed the difference between wet and dry AMD, and we mentioned that the wet kind was also known as neovascular AMD. One other study, the Beaver Dam Eye Study, found that current smokers were between 2.5 and 3.29 times more likely to develop neovascular AMD than never smokers or former smokers.
One final study that looked at the relationship between smoking and AMD was the Blue Mountains Eye Study, which concluded that current smokers were 4.46 times more likely to develop late AMD and nearly 5 times more likely to develop atrophic AMD and 3.26 times more likely to develop neovascular AMD than never smokers.
In short, the evidence linking smoking and AMD is surmountable and hard to argue with. Let's shift gears and look at other eye conditions.
In addition to their results that linked smoking and AMD, the Blue Mountains Eye Study and the Beaver Dam Eye Study also found that current smokers were more likely than never smokers to develop several forms of cataract and to require cataract surgery.
Regarding glaucoma, the Blue Mountains Eye Study found evidence that smoking increases intraocular pressure, which is a significant risk factor for glaucoma. But this study found no evidence that smoking directly increased the risk for glaucoma.
However, one other private study found that heavy smokers were 4 times more likely to develop primary open-angle glaucoma than never smokers.
To close out our section on smoking and eye health, we'd like to mention the reversibility of tobacco use. Many of you may be wondering, I used to smoke, but I quit. Do I still have an increased risk for developing any of these eye conditions?
To that, the answer is yes. In terms of lung health, after quitting smoking, your lungs begin to heal and lung function slowly recovers. However, regarding our eyes, former smokers still have an increased risk of developing AMD as compared to never smokers. However, this risk was lower than that of current smokers.
Additionally, an independent study which looked at a bunch of data from other studies found that there was a strong association between smoking and cataracts, such that even ex-smokers had a significantly higher risk than never smokers for cataract development.
We know that this section may have been a bit technical and overwhelming, but the summation of findings concludes that just as smoking is bad for your overall health, it is likewise bad for your eye health.
Although quitting smoking can be difficult, we are here to provide a couple of tips to quit smoking for good. The hardest part about giving up smoking is obtaining the right mentality. Finding a motivational reason to quit smoking is half the battle. Putting yourself in the right headspace will allow you to find the initial courage to give up smoking. It is also important to lean on friends and family who can help you through the quitting process. Having a group of people who are healthy influences that can support you is super important. There are also foods that can help you quit smoking. Visit our website, abvimichigan.org, to see the full list of foods that can help you quit smoking today. For this next segment, we'll look at what UV light is, how we can be exposed to it, and how it affects our eye health. You have likely heard the terms UV light or ultraviolet light before. These are the same thing, and our main source of UV light exposure is the sun. Other sources of UV light include tanning beds. Blue light is light emitted from electronic devices and can likewise be harmful to the eye. Visible light is just light, for example, light from a light bulb or the color of an object. Exposure to sunlight and UV rays can have detrimental effects of multiple aspects of the body, including the eye. We most commonly hear about the importance of wearing sunscreen outdoors, but in this episode, we'll learn about the importance of protective eyewear while outside.
UV exposure results in oxidative stress and damage to the eye, which can lead to increased risk for a multitude of eye conditions. Multiple studies have suggested that excessive exposure to visible light, blue light, and UV light has the potential to cause damage to photoreceptors, stem cells, and retinal pigment epithelium, all critical components of the eye. The stem cells in your eye help to repair and heal the eye after daily wear and tear. Therefore, if they get damaged by excessive oxidative stress, they can no longer serve to repair. The condition that is most strongly associated with excessive UV exposure is pterygium, which is a growth of tissue on the conjunctiva of the eye that typically grows towards the pupil. The conjunctiva is the white part of your eye. Several studies have concluded that pterygia occur more commonly among individuals who live in areas where UV exposure is the highest, for example, near the equator. Additionally, individuals who live at these latitudes during the first 5 years of their lives are 40 times more likely to develop pterygia than others.
The association between UV exposure, cataract, and AMD have also been examined, but are less conclusive. One study found that individuals over 65 years of age who lived in areas with a longer duration of sunlight suffered from higher incidences of cataracts than similar individuals who lived in areas with less sunlight.
Another study, which examined middle-aged fishermen in China, found that the risk for developing cataracts was significantly higher among men who spend 5 or more hours per day outdoors than among men who spent most of their time indoors.
There have also been several studies, including the Beaver Dam Eye study mentioned previously, that have found a positive relationship between amount of UV exposure and risk for AMD. However, it is currently believed that damage to the retina is caused primarily by blue light rather than UV light or visible light.
So how can you protect your eyes from UV light? Wear UV blocking lenses while outdoors. Currently, many eyeglass manufacturers are including UV protection as part of clear lenses, and of course, there are always sunglasses and transition lenses. Most importantly, never look directly at the sun or an open flame. Looking directly at either of these will burn your retina, destroying the rods and cones in your eye. These are critical components for vision. It can also create a small blind spot in your central vision, known as a scotoma.
Much like smoking, there is substantial evidence that UV exposure and blue light exposure are bad for our eyes. We must do everything we can to protect our vision while outside or exposed to sunlight. There are lots of fashionable blue light glasses as well as sunglasses that can protect against harmful blue light exposure and UV rays. We will now shift into the Q&A portion of our podcast. For this segment, we will be talking with Christina Hedlich, an occupational therapist for ABVI. Chris, welcome to the Triple P podcast. We are so happy to have you for this episode. Would you care to introduce yourself and let us know a little bit about you?
Sure. Thanks for inviting me. I've been an occupational therapist for about 28 years, and I've lived in Grand Rapids the last 20 years, and originally I'm from Kalamazoo. I went to Western, and I got my specialty certification from University of Alabama at Birmingham about 5 years ago.
Well, welcome to the podcast. Can you elaborate a bit about why you became an occupational therapist, and specifically why did you specialize in low vision?
I became an occupational therapist. I decided way back when, right out of high school, that I wanted to do a helping profession. My mom was a nurse, and so I explored different avenues for that. And I decided because I like being creative and having a well-rounded approach to seeing patients that I wanted to be an occupational therapist. And then the low vision specialty came up as I kind of got bored with doing regular occupational therapy at the hospital. And I wanted to do something different in the second part of my career. And so I went to a course that introduced me to low vision rehabilitation. And I decided to do the online coursework, and that led into my post-professional master's, focusing on low vision rehab. My grandma had some vision problems, as well as I grew up close to the training center for one of the training centers that the state has for blindness down in Kalamazoo. So I saw people all the time walking through my neighborhood with white canes and doing different training techniques. So it always intrigued me. So that helped too.
Can you clarify on how low vision differs from regular vision in the sense of visual acuities, peripheral vision, etc.? You mentioned that you saw people walking down the street with white canes, so to give a little bit more background about why that's important.
Well, low vision is when an eye condition or disease impacts doing daily tasks. I don't like to specify it just to a visual acuity or a side vision issue. It's really when somebody is struggling with doing things they want to do every day, or whether it's hobbies, whether it's simple things like getting dressed, doing their laundry. It could be caused from acuity issues, where that's a wide range with low vision. Blindness, we'll talk about that in a minute, has a very definitive legal definition on an eye chart. And then the side vision definitely can impair somebody from getting around, and then they will need further training. But it could be a combination of side vision, acuity, it could be glare, any of those things. Just seeing cloudy vision, all of those can play into having low vision.
So I feel like there are a lot of misconceptions on the differences between low vision and legal blindness. So what classifies someone as being legally blind?
So legal blindness is a federal definition. They had to come up with a level where people start being allowed to be eligible for certain benefits. And so with the eligibility, probably, I don't know the history, but I'm supposing it's based on more of a World Health Organization standard way in the past. But how we define it here in the United States is 20/200 on the eye chart, or if you have 20 degrees or less of side vision as determined by testing from an eye professional.
So specifically, how do you assist these individuals who are low vision or legally blind? And how does that compare to kind of what a certified vision rehab therapist might do?
So certified vision rehabilitation therapists and occupational therapists doing low vision rehab certainly overlap quite a bit. Occupational therapists are trained with more of a medical background, and we can bill insurance, medical insurance, if we have a doctor's order for doing low vision rehab. Certified vision rehab therapists bill private pay, or here at ABVI we have some grants that help that we can tap into for funding for that. Sometimes state agencies will pay for services as well. So certified vision rehab therapists have more training in blindness technique, so doing Braille. They have a little bit more exposure to assistive technologies and generally how a blind person needs to learn to function in their world. And we both do cover a lot of the daily living things, so that's where we overlap. I would say as an occupational therapist, I have more knowledge and training of medications, their medical diagnoses, like if they have other things other than just their vision that's an issue, that I'm aware of how that would affect other parts of their functioning. But we do complement each other. Certified vision rehab therapists do have their certain specialties. I think I tend to do more of the medication management, and they know more of the Braille and total blindness piece.
So you kind of mentioned assistive technology and devices. What types of devices specifically help with low vision?
So there's quite a wide range, but I put it in certain categories. Magnifiers are certainly the main thing that people start with. There are traditional magnifiers that are out there even at the store that don't have lighting attached to it, or maybe have a little weak LED light with it. We have a little more robust type of magnifiers that have better LED lights, but also can go much stronger here at the agency. So if people don't find the ones in the store helpful, there are stronger ones available here. Also, different lighting, knowing some options for different lighting, whether it's color or strength or where we need to place it for the working, what the person is working on. Tinted glasses or fit over glasses that have different color that might reduce glare are some things that we work with, and electronic magnifiers.
So what would your best bit of advice be to protect our eyes and our eye health?
Be sure to get an annual eye exam, even if you don't wear glasses, or if you've been told by an eye doctor that your vision can't be corrected with glasses. It's important because there are other eye conditions that can creep in that you can't feel, any pain with, that could dramatically reduce your vision and cause permanent damage. So it's always a good practice to do that, especially as you age.
Finally, what is your favorite or most rewarding part about working for ABVI or with the visually impaired?
I would say seeing clients regain their independence and engage in their favorite hobbies and activities they want to do again.
Well, Chris, thank you so much for joining us today on the third episode of our podcast. It has been a pleasure to have the opportunity to interview you, and you have provided such valuable insight into how we classify low vision and how occupational therapists can aid. Thank you.
Thank you.
And thank you all for joining us once more today and listening to our podcast. Next week, we'll talk a little bit about the less controllable genetic components to eye disease.
As with all of our episodes, the references from this episode will be uploaded to ABVI website should any of the studies interest you. Again, they're quite technical in their reporting. Thanks so much for listening to the Triple P podcast. If you would like to connect with us in between podcasts, make sure to follow us on Instagram and Facebook at ABVI Michigan, and make sure to join us next week. Thanks for listening to the Prevent, Protect, and Preserve podcast.